You're welcome. In this video, we are going to consider adrenergic pharmacology. That means drugs that are acting on the sympathetic nervous system. I also who say if we are the autonomic nervous system. Na sa autonomic nervous system no, yache mu mmienu. Yɛfrɛ one part sympathetic nervous system. And another part of it called parasympathetic nervous system. So two systems, when they're coming together, near friend the autonomic nervous system. You must be knowing that a sympathetic a bra or fight and I will fight, or when I say the fight or the flight mode. And a parasympathetic a bra or home now like all digested things in your stomach. There are two systems, the sympathetic nervous system and the parasympathetic nervous system. Now, saa two systems we and as a carbon your friend the autonomic nervous system. In adrenergic pharmacology, that is drugs acting on the sympathetic, and cholinergic pharmacology, that means drugs acting on the parasympathetic nervous system. In this section, you have drugs acting on the sympathetic nervous system. But before saying I was saying natural one is fire. I was all say even without drugs, no, a sympathetic hormones be released. Sorry, neurotransmitters be released. Now could stimulate receptors be the actions be a brain. And the person can ye pa. So sympathetic nervous system about team fan say Kraman HSU. Na Kraman HSU no. Any abeng and say change your body name. The demand wow na webjane. That will be another state of sympathetic nervous system. Internationally, no, body release name maybe a stimulative receptors be na amwenya the action that we need. A bit me so ama yendro bi a drone wa stimulative receptors no ama ebedwen say the normal endogenous substance our body name na stimulative receptors no and air causes meanwhile so drugs be a bit me bind to it na amasa changes na come on HC me and change no drugs and sweet cause the same thing. In adrenergic pharmacology, we are only going to look at the drugs on the sympathetic nervous system. The way drugs are a beboa and may stimulate the sympathetic, drugs are M1 and answer inhibit the sympathetic nervous system. Until say at assessor, or person kind near my coso, I was sympathetic in one macatron beam say. Sacrament HSU and a woodjane. What should be the changes in the body? Should the people dilate and answer then? Sanaman evidence you. It's about talk about it in no time. Into drugs acting on the sympathetic nervous system. Now we have drugs that may make the action of the sympathetic nervous system. It matures normally no. Menu and the state of the fight or flight crime chasing neurotransmitters be released about the name. About stimulation receptors be ama changes be or occur about the name. Wabra menu no. But now automatically from the autonomic be released name be aqua stimulative receptors be na cause the action that I need. Now mainly and that state. Na person must chasing be okay there. Make me a fair drew beer. Say drew ever call. Akoko yes changes na ka kama HSC me a ka ese cause no. A drew bit me as hard. Now, adrenaline bit me aside the from the sympathomimetic. Drugs that may make the action of the sympathetic nervous system. Drugs that decreases sympathetic outflow, that increases sympathetic outflow, similar to the sympathetic innervation, are called sympathomimetic. Send neurons are the adrenergic drugs and adrenergic agonist. We produce pharmacological action similar to the sympathetic nervous system. Much when I say the sympathetic, more release endogenous neurotransmitters be backward stimulatory receptors. But in some of the be as I do not access just in a body now be releasing in send known from the sympathomimetic and adrenergic drugs and adrenergic agonist. Every day, I say, you will know one man and also could decrease the sympathetic activity. And I say the pharmacological activity as if sympathetic nervous system is blocked. In the new one man, echo buema could stimulate the sympathetic nervous system. Say no, you're from saying sympathomimetic, adrenergic drugs, and adrenergic agonist. And you will know the new ones are about the opposite. About decreasing. Hormone you form then the sympathetic drugs, anti-adrenergic drug, adrenergic antagonist. They are the same drugs, class of drugs. I was say so now before we go to the normal process, we need to know something about the neurophysiology and the neurobiochemistry of the sympathetic nervous system. If we are never here neuron, may increase the sympathetic nervous system, and as a may decrease the sympathetic nervous system. Right. So we are seeing a diagram here, and this diagram of we call okay. So this is the neurophysiology. Into adrenergic pharmacology, I'm kind of yeah, your friend with the sympathetic outflow, and now thoracolumbar outflow. I did a mere sympathetic nervous system, no. The same the phobia meeting, the thoracolumbar outflow. I didn't ya. Now you didn't ya. Now there's someone who been on the brain and the spinal cord in. Good. Now a can bear so the first one. The sympathetic nervous system, it means cause man stimulate receptors be any organs be and man cause the action that is required. Now woman ye makacho say what is sympathetic? For sure team say a crime HSU dog is chasing you. Change is brain, I think say it should occur in the body. This is the sympathetic nervous system. Because para now come on chasing we what about them? You are resting and digesting. What are the changes that should occur in the body? Almost animal way now. What the wild dream club to me and I can yama like a wow. I'm out bit me. I kind of ye. I won't call about baby. Into where someone the brain and spinal cord. Now the brain there's a special something here called the limbic system. So our limbic system we know is involved in emotions and behavior. And then more I did my draw here and so the hypothalamus. Hypothalamus no at the higher brain center. In the end, say, sorry. Okay, me drew. The infant say, me sorry, matching by 3 a.m. And I make one dog be chase me. Na me tick kamane so kamane boomer, a one no be me. Them say sympathetic activity as started increase. Changes by started okay in the body. And you may be able to am more free come on another area, no, those structures are going to be stimulated. Maybe a M1, so those structures are going to be inhibited. The M1 maunano, no, they are going to be inhibited. What will be the initial action for sympathetic outflow? Now, we limbic system and we hypothalamus. hypothalamus is champion. The first part, the anterior part, no, and no air for the parasympathetic innervation, and I actually near the for sympathetic. Now, even a woman, limbic system, now me quite sorry. My sister cramine air back. Cramine back here now, my son, the temporal lobe area. Into that part will send an info to the limbic system. Now, as a signal to sympathetic, say, I did be a year bow. Into better signal from the limbic system, no, ever back to the sympathetic part of the hypothalamus. After what come on back and from the year now, after you might be tempted to look back into over than when I watch it. So we won't come on. Now, so you come on as soon. Now, you may show, right? Into from your hospital lobe, no, so a better signal to your limbic system. Now, limbic system so as any signal to the sympathetic part of the hypothalamus. Now, if we same panel, increase. Now, if you want to move bida. Now, moving out where you're not to say, not come I mean so HAC ubisa. But I know dear. Ne or chain like or cano. We am sure into parietal lobe now they moving. Now, what the caca, from parietal lobe, no, and info everybody the limbic system when I beam. About when I beam now fee. I will send a signal to the sympathetic parts of it. Now, face I belong to me, but influences are working from frontal lobe. I will send a signal to the limbic system. Then also the signal now upgrade the sympathetic part of the hypothalamus. And at the end of the day, no, once the sympathetic activity no increase. So the more you think, the more you look, the more you hear, the more sympathetic activity is increasing. Now, I'm fine. So the signal now brothers, the signal no upgrade the sympathetic parts, okay, of the hypothalamus. Nyafi nyakwa say, I feel almost I there are neurons, some polysynaptic neuron be coming from the sympathetic part of the hypothalamus. I feel belly sending up or down. It be sending up or down. But it's our signal now. Being by a stimulate polysynaptic neuron way up or down. None nyakwa now your bar in swa. Once I the cervical area from this part to this part and so the thoracic area. This part, okay, and so the sacral, sorry, the lumbar area, and I have to be the sacral area. Now, it's a sympathetic part of the hypothalamus, no, if it is stimulated, the postsynaptic neuron, no, but down, all stimulated will be out, baba, I be stimulated cell bodies are a what the thoracic area in. So, how is it into the signal or the signal, them say, oh, stimulate the cell bodies in the thoracic area. Now, if you're somewhere down, or some stimulate the cell bodies in the lumbar area. And when sympathetic part is activated, they only stimulate, even though there are cell bodies they won't stimulate, they only stimulate cell bodies in the thoracic area and in the lumbar area. And for sympathetic, they stimulate only the thoracic area and the lumbar area. The sympathetic outflow and thoracolumbar. That means the thorax and lumbar. In this thoracolumbar, it means a sympathetic outflow and a campasum. So a parent so how best stimulate cell bodies in different areas. You do on so and to note that the cell bodies here will be stimulated, but they'll be it's only the part of the thoracic area and the lumbar area that the signals from the sympathetic part of the hypothalamus will come down and activate. I'll be just we don't if you want to activate it and not no action be going on here. Right, this is cell body. And of course, there should be an axon. Okay, so within the body, so I say, once I do there around the ganglion. And the ganglions are outside the brain and the spinal cord. Okay, they are outside. And there's a ganglion. Now, there are neurons. Where is cell body? And of course, the axon will be coming to the ganglion. Now, for instance, and the neuron will be free the ganglion. I call the effector site where receptors are going to bind. And you see neurons na oba before the ganglion no. Sorry, no. You find the preganglionic neuron. Preganglionic neuron. Na neuron na ebaja ganglion na say if ganglion we call we are receptors ne one. Almost from the post-ganglionic neuron. But idea back question when say in the sympathetic outflow no, pre-ganglionic neuron no, and what to say the post-ganglionic neuron. In another way, say the post-ganglionic neuron in sympathetic outflow, they are longer than the pre-ganglionic neuron. But the para sympathetica on pre-ganglionic neuron ewa say on post-ganglionic neuron. But for sympathy, the post-ganglionic neuron ewa saying the pre-ganglionic neuron. I just say good. Now need to be say pre-ganglionic neuron a release them. Release a neurotransmitter called acetylcholine. They release acetylcholine. Now if you were stimulating receptors on the post-ganglion neuron, now if you also stimulate, now if you also release them, more of norepinephrine. Release norepinephrine, be like 90%. No release epinephrine, kakrebi, by 10%. And dominantly there, they release by norepinephrine. That is post-ganglionic neuron when they are stimulated by the neurotransmitter called acetylcholine. A bunch of receptors now are saying now activating now epinephrine and epinephrine now bind to the receptor no adrenergic receptor. Upper receptors are epinephrine no bind to the adrenergic receptors. But as soon as the post-ganglionic neuron will release more of norepinephrine and epinephrine will release more of norepinephrine or release epinephrine a craving. That's it. Now, acetylcholine also bind to receptors B on the post-ganglionic neuron. So receptors no they form nicotinic receptors. Acetylcholine will come from the preganglionic neuron and they will stimulate what the nicotinic receptors here and they will activate this post-ganglionic neuron. This also come. Now, if you release norepinephrine, now if I stimulate the receptor here called adrenergic receptors. However, there are some preganglionic neurons. Some preganglionic neurons come here, get to the cell in the ganglion. Once I see you do, move release signal. I say no do no between. Into a bit ganglion now, they pause and release a neurotransmitter and stimulate the other post-ganglionic neuron. A bit so on ma or bape. Only now, no trim. Until I still have my preganglionic neuron to be this one. They will go directly and stimulate a structure called adrenal medulla. Adrenal medulla. Okay. On top of the kidney. Now, I will release more of epinephrine and little or no epinephrine. But post-ganglionic neuron, it releasing more of norepinephrine. But adrenal medulla, it be releasing more of epinephrine. Into the predominant place for epinephrine and norepinephrine, yeah. Post-ganglionic neuron, it releasing norepinephrine. And a medulla, it releasing epinephrine. But there will be little or no release of the other part of it. Into accident to release a crave of norepinephrine. Little or no. As is a crave of epinephrine. So note the difference. Now, what have I said up to this part? Let's say what is sympathetic activity outflow? And I'll see that to columbar outflow. When you say come HEC, what are the things that should go on in the body? Later. But here, what to start and say now, what's a command voice now? The auditory lobe, the temporal lobe will send signal to the limbic system. Now, what's the what do you call? What's the voice and so so which one is correct command answer? The occipital lobe will send signal to the limbic system. Now, what you call okay, move be say movie no say camera chase obi saa Come on, I know chase will be sir. Now, Kana, it will be ye pa. I want to temporal lobe, ever sending info and a signal to the limbic system. Now, if you be one say it to come out to be a no signal saba. At the end of the day, no, the limbic system back then na when I come out the sympathetic part of the hypothalamus. That's the higher brain center. Now, if you was or the different the polysynaptic neuron, I did say, baby, I've been with cell body beer with thorax and lumbar area and media activity. No. It's when they come here, they will activate cell bodies in the thoracic area and they will activate cell bodies in the lumbar area. Anything flow on the thoracolumbar outflow. So it is sympathetic and one then thoracolumbar. So one. So when they are active, they will also stimulate the neuron. And we have a ganglion here, okay, and we have a neuron that goes after the ganglion. We have a neuron, so a bar before the ganglion. Yes, in the bar before the ganglion, your friend saying the preganglionic neuron. Near echo after the ganglion, friend is saying post-ganglionic neuron. Now, the preganglionic neuron, no, you see, it will easy neurotransmitter be your friend is saying acetylcholine. And the post-ganglionic neurons will easy neurotransmitter being norepinephrine more and little of what epinephrine, and they will stimulate what receptor? Adrenergic receptors. So norepinephrine and everything is going to stimulate adrenergic receptors. However, acetylcholine is going to stimulate nicotinic receptors on the ganglion and also on the post-ganglionic neuron. What I say, and I'm say, on say I say no, no, a koya a bit snaps with the ganglion. Wha a we a pray or do ganglion when you now and release your transmitter and I'll bypass it. And I'll go straight to adrenal medulla. And I'll really see ma adrenal say or the acetylcholine in terms of bread or brain acetylcholine. Not a stimulate adrenal medulla. No release epinephrine and no epinephrine. But more of what epinephrine. Now for your system circulation. Now also alcohol structures no or now stimulating. Send a vehicle stimulating now. But we be releasing into blood. Then so up pump all parts of the body. Alcohol stimulating. So into preganglionic neuron. The same thing here. Into we have preganglionic neuron. We also a preganglionic neuron. They all release what acetylcholine. We have post-ganglionic neuron. But we any post-ganglionic neuron, but our modified post-ganglionic neuron. That is what adrenal medulla. Are you okay? Now let's go and know how norepinephrine is released, and let's know some other drugs that can affect it, the release. Are you okay? Yes. So this is a structure talking about how norepinephrine is synthesized. Are you okay? Now it's not this is okay, fine. How norepinephrine is synthesized. Are you okay? Now, norepinephrine is a micromolecule. It's a synthesized here. You're forming the nerve ending or starting with the cell body. Now about to the ending. And I said to the part of the membrane parts and some better there be forming now or the ending part of the axon when I be forming. And how is norepinephrine? I can say norepinephrine is released dominantly in sympathetic activity. No, norepinephrine are released. No, a quite best and fast we know norepinephrine from the body as a neurotransmitter. Now, how could stimulate the cell bodies? Sorry, I could stimulate the receptors in TMA. Now, when I take in protein, let's say protein in the body, right? Protein will be broken down by an enzyme to, let's say, amino acids. And one of the amino acids is called tyrosine. Again, protein will be broken down to amino acids. And one of the amino acids is called tyrosine. Now, when I get this tyrosine, there's a pump here. So that will pick the tyrosine into, let me say, the cell. That picking into the cell. So here I have tyrosine here. Protein was broken down to amino acids. One of the amino acids was tyrosine. Tyrosine will be picked up by the pump, and then it goes here as what? Tyrosine. And I have tyrosine in the cell. But I don't want tyrosine. I want norepinephrine because I want to know how norepinephrine is released. I want to know how norepinephrine is released, not tyrosine. So I need to go further and know how norepinephrine will be released. Understand? How norepinephrine will be released. So I have protein here broken down to amino acids. Amino acids, one of the amino acids is called tyrosine. Okay, and tyrosine will be picked up by this pump and send it into what? Into the cell. Now, an enzyme called tyrosine hydroxylase will act on this tyrosine and convert it into what? Into dopa. Protein is broken down to amino acids. One of the amino acids is called tyrosine. Tyrosine is picked up by this pump into the cell. An enzyme called tyrosine hydroxylase will work on the tyrosine and convert it into what? Dopa. I don't want dopa, I want norepinephrine. So an enzyme called dopa decarboxylase will still act on dopa and convert dopa into dopamine. And convert dopa into dopamine. Okay, convert dopa into dopamine. Now, one thing I say, there is an enzyme called monoamine oxidase on mitochondrion. Monoamine oxidase on mitochondria. They eat up dopamine. So if dopamine is formed when dopa decarboxylase works on dopa and gets dopamine, this enzyme will eat up the dopamine. The bad is high, I wouldn't get norepinephrine. And there's a transporter here, vesicular associated transporter, will pick this dopamine into a vesicle, a membrane-bound vesicle. And when they are bound, this monoamine oxidase cannot eat the dopamine. Further, so here I have dopamine here by the V80, vesicular associated transporter, moving dopamine into the vesicle. But I want norepinephrine, not dopamine. So an enzyme called dopa beta hydroxylase will also work on dopamine and convert it to norepinephrine. Now I have my norepinephrine here. Very simple. So let's go again. What is happening? Protein, okay, is eating. Let's say in the body is broken down to what? Amino acids. And one of the amino acids is what? Tyrosine. So to get to norepinephrine, there's a pump here. And this pump will pick up the tyrosine into the cell. When it's picked up, an enzyme called tyrosine hydroxylase will act on tyrosine and convert it into what? To dopa. But we want norepinephrine, not dopa. So an enzyme called dopa decarboxylase will act on dopa and convert it into what? Dopamine. But I want norepinephrine, not dopamine. Okay, and furthermore, this enzyme called monoamine oxidase eats up this dopamine. They eat dopamine, they eat norepinephrine. So this thing here needs to be sent to a membrane-bound vesicle. And once in the vesicle, this enzyme cannot eat it up. Because if it's allowed to eat it up, at the end of the day, you will not get norepinephrine. So this channel here, vesicle associated transporter, will pick dopamine into the vesicle, and an enzyme called dopa beta hydroxylase will act on dopamine and convert it into norepinephrine. And now that's how our norepinephrine got synthesized. It needs to come out to stimulate the receptor here. Okay, so how does it come out? Now here, there's a protein attached to the vesicle, this vesicle. Okay, there's a protein attached. That protein is called synaptobrevin, this plaque. And it have a point where it attaches to another protein called synaptotextrin. So how can vesicles fuse to the membrane and release the norepinephrine out to stimulate the receptors at the effector site. What happens is that calcium ions need to enter the cell, okay, with the calcium channel. They need to enter. And once they enter, the synaptic brevin can fit into the synaptic textin. And once they fit into that, then the vesicles automatically you can also fuse with this one. So by these two proteins fusing, one is on the vesicle, one is on the membrane. They can fuse together when calcium enter the calcium channel into the cell. The moment calcium enter into the cell, then the protein part and this part will fuse together. And by way of that, doing that, they are fusing the vesicle to the membrane. Okay, so synaptic brevin or the vesicle fuse with the synaptic textrin of the membrane. And once they fuse, they are fusing the vesicles to the membrane. Okay, and when that happens, the vesicle fuse with the membrane, and therefore when they fuse, it is able to release the norepinephrine out to stimulate the receptors here. So without the synaptic brevin and synaptic textin, vesicles cannot fuse. So that's how norepinephrine is synthesized. Again, let's go over one more way. Protein is broken down to amino acid. Amino acid, one of the amino acids called tyrosine. Tyrosine is picked up by the pump and to the cell, have tyrosine here, right? An enzyme called tyrosine hydroxylase will act on tyrosine and convert into what? DOPA. An enzyme called dopa decarboxylase will act on DOPA and convert into what? Dopamine. So dopamine will have say an enzyme reference and monoamine oxidase. It can eat it up too quickly. Vesicle associated transporter need to pick this dopamine into the vesicle. And when it gets in there, I don't want dopamine, I want norepinephrine. So an enzyme called dopa beta hydroxylase, okay, will act on dopamine, and then you get norepinephrine. And I have a protein attached to the vesicle and a protein attached to the membrane. The one attached to the vesicle is called synaptic brevin, and the one attached to the membrane is called synaptic textin. When calcium enters the cell, that is where the synaptic brevin is going to really attach the synaptic textin, and when they attach, it fuses the vesicle to the membrane, and therefore releases the norepinephrine. That is, releases the contents. That is that. All right. Now, there is a reuptake mechanism 1. There is reuptake mechanism 1. What is happening when norepinephrine is released and bind to the receptor? It goes back to reuse. Unlike acetylcholine, where it will be broken down by acetylcholinesterase. For norepinephrine, the moment they bound to receptors and they finish the activity, they come back and they are taken back into the vesicle to be reused. So this is reuptake mechanism 1, where it takes the norepinephrine back and then go into the vesicle. Again, so with the reuptake, when they bring norepinephrine in, and norepinephrine is not taken into the system or the vesicle, monoamine oxidase can act on the norepinephrine again and eat it up. So when I start to eat it up, at the end of the day, I'll have my vesicles coming here, but nothing will be released because monoamine oxidase has eaten the norepinephrine. So when it comes into the cell again, quickly, it needs to go to the vesicle by this same pump again. This is called a 12-pass receptor. This is called a 12-pass receptor, okay? And for this 12-pass receptor, what they do is that norepinephrine binds to it and auto-inhibits. This is a 12-pass receptor. So norepinephrine can bind if more of norepinephrine is releasing. When norepinephrine binds to this receptor, it decreases the production of norepinephrine. So they auto-inhibit. So 12-pass receptor on the membrane of a preganglionic neuron is auto-inhibitory because norepinephrine can bind to it and then decrease the production of norepinephrine that is coming. So that is all about the synthesis of what? Norepinephrine. And some things you know. So there can be a drug to block this reuptake. So that I have more of norepinephrine in this cleft. Because if a drug targets here and block the system, norepinephrine will not be released. So I have more of norepinephrine here. You understand? So we get to know drugs that are going to work on this one, and we get to know drugs that are going to work on this one and some other structures as well. Okay, good. Now you have drugs. You have drugs. We have drugs that are going to. We have drugs that are going to act on different parts of this area. Okay, we have drugs that are going to work on different parts of this area. We need to know this kind of drugs. Okay, now the first drug to talk about is methyl-tyrosine. Methyl-tyrosine inhibits tyrosine hydroxylase. Methyl-tyrosine inhibits tyrosine hydroxylase. Where is tyrosine hydroxylase? Tyrosine hydroxylase. So methyl-tyrosine comes here and inhibits this enzyme. So when tyrosine is taken in, because this enzyme has been inhibited by the methyl-tyrosine, it cannot act on tyrosine and convert it into dopa, and therefore you cannot get the norepinephrine we need. So this is sympatholytic drug because it doesn't allow us to get norepinephrine released as the normal body will do. You understand? So this drug becomes a sympatholytic drug. So it inhibits the tyrosine from working on tyrosine to convert it to dopa. So that is methyl-tyrosine. There's a drug called reserpine. It stops vesicle transporter from picking dopamine. So this is where a reserpine will act, a drug called reserpine. They will act on this transporter. So they will bind this transporter and will not allow dopamine to be picked into the cell, the vesicle, and therefore monoamine oxidase will act on dopamine and eat it up. So this drug, reserpine, to becomes what? A sympatholytic drug. They bind to this VAT transporter and prevent dopamine from taking into the cell. Guanadrel or botulinum prevent vesicle from fusing with membrane. So guanadrel or botulinum is a drug which breaks the system down, the protein part of it. It breaks this system down. It eats up the system. You need the proteins here to fuse the vesicle to the membrane. But when these proteins are eaten up, then vesicles cannot be fused. And when it's not fused, norepinephrine cannot be released into the synaptic cleft and stimulate receptors. So this drug becomes what? A sympatholytic drug. And that drug is called what? Is guanadrel or botulinum. They eat up the protein part of the vesicle and then the membrane, and therefore prevents the vesicle from fusing the membrane, therefore releasing the contents. So when they eat these things up, norepinephrine will not be released. Why? Because the vesicle cannot even fuse to the membrane. Another drug is called alpha-methyldopa. This is not a rare dopa. There's a drug called alpha-methyldopa. You know what it's going to do? Alpha-methyldopa will be picked up by a transporter into the system. So when it comes here, it will be alpha-methyldopa. This enzyme will confuse the alpha-methyldopa and dopa. So instead of working on the dopa, they will work on the alpha-methyldopa because the alpha-methyldopa is like dopa, only that methyl group has been attached. So dopa decarboxylase will act on the alpha-methyldopa, this drug, and convert it to alpha-methyldopamine. And at the end of the day, you will not get norepinephrine. You get alpha-methyl norepinephrine. And alpha-methyl norepinephrine. So when I release here alpha-methyl norepinephrine, then I'm going to stimulate a receptor. So this drug fool the system. This drug fool the system. They act as dopa, but they are not dopa. This drug actually fool the system. So it becomes a sympatholytic drug. Now let's get to know another class of drug. This is cocaine. It blocks reuptake of neuron. Yes, so here cocaine works here. Cocaine and prevents norepinephrine from taking to the system back. Cocaine works here and block this reuptake. So I have more of norepinephrine here, but it will not be taken. And you know that norepinephrine and all these things keep us excited. Okay, so realize that if they're left here and they're not taken back, I'll get excitement. So those who take cocaine block the reuptake of this one, and norepinephrine is not taken back. And when I have more of norepinephrine, I have more of excitement. That is why they do that. Now, drugs binding of receptor to membrane to release norepinephrine. So you have drugs here called amphetamine and tyramine, binding of vesicle to membrane. So amphetamine and tyrosine works here, and they increase the fusing of the membrane to the vesicle to membrane. So they facilitate the binding of vesicles to membrane. So they become sympathomimetic drugs. Okay, so tyramine and amphetamine make sure that there is enough fusing between the vesicle and the membrane so that it releases the contents as norepinephrine to stimulate receptors. So these are the drugs that we talk about it for now. Adrenergic receptors. Let's get to know adrenergic receptors. So to increase the sympathetic activity, norepinephrine or epinephrine should be released. If it is post-ganglionic neuron, it is going to release more of norepinephrine. And if it's a adrenal medulla, it's going to release epinephrine. So for sympathetic activity to increase, there should be a release of norepinephrine and epinephrine. And these are going to alter tissue function. Now, the norepinephrine or epinephrine should go and stimulate, can go and stimulate or going to inhibit certain structures. Okay. Now, we have receptors for sympathetic outflow. These receptors are called what? Adrenergic receptors. But I have various of them, many of them. We have structures or receptors that are stimulatory receptors. So for the alpha-1 and beta-1 adrenergic receptors, they are stimulated. So when norepinephrine binds to these receptors, they are stimulated. But for the alpha-2 and beta-2, they are inhibited. So when norepinephrine binds to alpha-2 and beta-2, they are inhibited. But if I want the one that will be stimulated, alpha-1 and beta-1 are stimulatory adrenergic receptors. Okay, so we have, let me see, now I have 4 here. Okay, alpha-1, beta-1, alpha-2, beta-2. The ones are stimulated ones, and then the 2s are the inhibited ones. Simple as that. Okay, but we have, okay, so now let's do something here. All the tissues which should be stimulated by adrenergic system should have alpha-1 receptor, except few that you have beta-1. So we are seeing that the stimulated ones are alpha-1 and beta-1, but most of them are alpha-1. We will have a few that is having beta-1, and the beta-1 is what? On the hearts. So beta-1 receptors are on the heart. They are stimulatory ones. Kidney, I'll get beta-1. That's the glomerular for beta-1. And lymphocytes or adipocytes, I have beta-1. But that beta-1 in adipocyte is modified. They are modified beta-1. And a modified beta-1 is what? Beta-3. So all tissues in the body which should be stimulated in the case of sympathetic outflow are alpha-1 adrenergic receptors. However, there are few that have beta-1. So beta-1 on the heart, beta-1 on the kidney, and lymphocytes. These are having beta-1. And lymphocytes are having modified beta-1 called beta-3. So when all these structures are giving norepinephrine, they're going to be stimulated and cause the action that we need. On the other hand, we have receptors there that are inhibitory, alpha-2 and beta-2. When norepinephrine binds to them, it becomes inhibited, and that organ or that structure they found themselves will not be stimulated. So yes, so all tissues to be inhibited should have beta-2. So you're talking about the inhibition one. All tissues to be inhibited should have beta-2 AR, adrenergic receptor, except some few parts. The GIT is having alpha-2, platelets having alpha-2, and presynaptic nerve ending, they're having alpha-2 receptors. So you should know that. Now, all tissues to be stimulated should have alpha-1 and beta-1. And all tissues to be inhibited should have beta-2 and alpha-2. But you should note for the stimulatory that many of them are having alpha-1. A few is having a beta-1. The heart kidney, and what? The lymphocytes. All tissues to be inhibited should have beta 2. You will have a few that's having what? Alpha 2. So you know that as well. Now, sympathetic activity, the flight or fight mode. I told you that whenever you think of any sympathetic nervous system outflow, when I say a dog is chasing you, say if a dog is chasing you, what are the things that should go on? You understand? So an example, a dog chasing you. So all the actions that are going to occur in the body, no, and then the sympathetic activity, no. So if a dog is chasing you in the evening, let me say around 10 p.m., you want to run away. Do you think people should dilate so that enough light can go into the eye so they can run? Or your people should constrict so they have few lights going in there? Automatically, your people should dilate so they have more lights coming into the eye so they can run. You can run away. So people should dilate. And if it is dilating, they should be stimulated. So that means that alpha 1 is going to work here. You talk about that. So it should be stimulated. Now, ciliary muscle should be relaxed. You want to run away. Do you think your ciliary muscle should be relaxed? If they are relaxed, it's not making accommodation. But if it becomes stimulated, it will bring about accommodation. And if you accommodate to see it near, and if a dog is chasing you, you don't want to look any area that is closer. You want to look at the far places, maybe an alcohol. And if a dog is chasing you, do you want your eyes to accommodate? Or you don't want to accommodate, but you want to see as far? Of course, you want to see as far. That means that your ciliary muscle should be relaxed. And if it's relaxed, you want to see as far. Okay, so then the ciliary muscle should be what? Relaxed. And it's going to relax, that is going to be what? Inhibited. So accommodation for far vision, you understand? Now, bronchial smooth muscles relaxed. You are run away. Your airways, do you want it to open so I get more of the oxygen, or you want it closed so I get few of the oxygen? So you want it open. That means that the bronchial smooth muscles should be relaxed. If they are relaxed, the airway becomes big enough so they can run. By running, you get more of oxygen to run away. Now, you are running. Skin all over the body should be pale. Skin and cutaneous vessels should constrict. So they should be stimulated. So skin all over the body should be pale. So skin hair pale. And your cutaneous vessels then should constrict. I didn't say because the human cow. And if those parts are well having more of blood over there, human cow you have more, you bleed more. And those automatically those vessels then should become smaller. So you have few blood coming out. So they should be stimulated. And when vessels are stimulated, the vessels become very small. So it doesn't send more blood to that area. So for skin, vessels should be small, they should be stimulated. Now, skeletal muscles needs increased blood flow. Skeletal muscle, and skin, we need these muscles to run. And they should get increased blood flow until say a dilate. Say dilate there, and they say inhibited. Say inhibited, say if they are inhibited, a very relaxed, if they are stimulated, a very if they are stimulated, their vessels, the muscles, if anything, so there'll be little or no blood going to that area. But because they want increased blood flow for vessels, so vessels, if vessels are stimulated, they become smaller. If they're inhibited, they become bigger. Except vessels in the and more blood going to the skeletal muscles. Now, kidney, you are run away. You don't want to stand somewhere and urinate because if you stand, the dog will bite you. So you don't want to urinate. So smooth muscles should constrict. It's like urine cannot pass out. Heart function should be increased. It should be stimulated. Do you think say? So automatically your heart will beat faster. That is a tachycardia. Tachycardia. So heart will beat faster. So they are stimulated by beta 1 receptors. So look at those receptors again. So distribution of different adrenergic receptors on different tissues. Okay, so let's look at areas and let's look at the receptors that are there. Now, for hair to stand, you have the erectile pili. And that's why some of the animals are more realize that their hair it is so yes, it is happens that way just to scare the other animal. You understand? So you have hair to stand, you have the erectile pili. They should be stimulated. When they are stimulated, the hairs will stand, and that will be as a defensive mechanism. Now, eyes, radial muscles, alpha 1 to cause pupil dilation. So the alpha 1 receptors are on the radial muscles, and when they're stimulated, it's going to cause pupil dilation. Now, accommodation for far vision. I told you that there should not be accommodation. So on the slave muscle, it should be inhibited. So inhibition, there, I may say, all muscles to be inhibited should have beta 2, except few should have alpha 2. And since I may say the slave muscle should be inhibited, yeah, then they should have what? Beta 2. Because the alpha 2, A for platelets, A for the GIT, and then some other structures what I said previously. Skin and cutaneous vessels should constrict. I was like, and it's hard. More blood will come there, and when the dog bites you, you're going to bleed. So I have alpha 1 to stimulate the vessels there so they constrict. On the heart, I have beta 1, beta 1, beta 1 to cause tachycardia. So your heart beats faster. Bronchial smooth muscles should be inhibited. If they're inhibited, they become bigger, and the airway becomes bigger, and I have more air going that way to run very well. So beta 2 receptors and what's on the bronchial smooth muscles. Pancreas, I have alpha 2, as I said earlier. Skeletal muscles, I have what? Beta 2, they should relax. So I have more blood coming there to help me run. Urinary bladder smooth muscles, you have beta 2. Okay, the urinary bladder smooth muscles have beta 2, and the urinary bladder sphincter. So you have alpha 1 should constrict so that urine doesn't pass out. All right. So that is that I'll talk about for now. That is part 1 of this. I'll go to the main thing. This is an overview. Okay. So note say you can say the sympathetic camera is chasing, a dog is chasing you. What are the things that should change the body? Automatically. You should know these things. Baba. You understand? Yes. So when you know these things, you know how the drugs are going to work. So if nothing at all, so you've gotten to know where the drugs act on the sample. You have the this kind of drugs acting. We have the outflow. We know what is going on here. We know how they synthesize and comes out. You know the different drugs acting on them. The receptors here. Those are stimulatory and those are inhibitory. And then we talk about all these, and they have the activity things that are stimulated and inhibited, and we know the distribution of receptors on different tissues. In the next video, we are going now to talk about the real adrenergic pharmacology, but we've basically summed everything up. Okay, thank you.